So, hello and good evening, everyone. Welcome to the 129th Blue Health Virtual Seminar. Blue Health Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And today's virtual seminar is brought to you by Blue Health Ethiopia with International Society of Sexual Medicine as part of their global outreach initiative. So, Blue Health Ethiopia is a medical consulting skilled and I'm your host, member of International Society for Sexual Medicine. Today, it's a pleasure to have Dr. Abebe Assefa here with us to have a presentation on optimizing menopausal care, lifestyle changes, management, and patient counseling. Dr. Abebe Assefa is a consultant obstetrician and gynecologist at Joy Obstetric and Gynecology Specialty Clinic. He completed his medical degree at Haramain University and his specialty in obstetrics and gynecology at Yekatit Ashort Hospital. Dr. Abebe, the stage is all yours. You can begin.
Okay, thank you for the generous introduction. So my name is Dr. Abebe. So today we will see one of the most important women health issue, which is about menopause and the menopause related issue. So before we start the discussion, let's see, sorry. So let's see the contents of the discussion. So, and first we will see introduction, and the next we'll see the how patient evaluation and current approach to hormonal replacement therapy and with evidence, and we'll see detailed menopausal major symptoms with their principles of management. And this has the acronym and abbreviation. So as an introduction, menopause is, as you know, is a word derived from Greek words. Men means month and pause means cessation, is cessation of menses. And the menopause is a point in a time that follows 1 year after complete cessation of menstruation. That's due to loss of ovarian activity. So normally, ideally, the average age of menopause is around 51.5 years, and this age can be so this age, the age of menopause can be earlier, can be affected by different factors, and whereas when you see menopausal transition is a progressive endocrinologic decline in hormone levels. So that takes a reproductive aged woman to her final menstrual period. And ideally, this menopausal transition is it starts on average from 42 years to 58 years old, up to 58. And the average age of onset of menopause transition is around 47 years. So normally, this menopausal transition is there are different terms for menopausal transition, which it's currently we use menopausal transition, but it's in other words you can say it's as perimenopause as well as climacteric. And normally, currently, menopause is great. It's one of the most women health issue because the life expectancy of women is increased. So you can see the graph here. So as you can see here, currently the life expectancy of female is almost increased to an average of up to 81 years. So almost 1/3 of the lifespan of women spend their life in menopause. So due to that menopause health is a great concern currently. So, for example, in Ethiopia, even around 60% of women aged between 30 and 49 are in menopausal, and as the percentage of menopause of women increase as the age of the women increase. You can see the graph here. And when it comes to the current Today's important discussion is, as you know, menopausal transition is, as I said, it's late reproductive years. It's the late reproductive years, usually in the late 40s to early 50s, which is characteristically begin with menstrual cycle irregularity and which extends to 1 year after permanent cessation of menses. So, because as I said before, menopause means is a point where a point after loss of her menses for 1 year due to loss of ovarian activity. So before 1 year, so it is menopausal transition. So it's a wide range of years. It's, as I said, it includes from, it may start from 2 years up to 58 years, and mostly this menopausal transition may last up to 4 to 8 years. So as you can see here, during menopausal transition, so there is erratic fluctuation in female reproductive hormone levels, which leads to some physical as well as psychological symptoms. So as you can see here, the table, there are different symptoms of which a woman will have during menopausal transition due to fluctuations of reproductive hormones. We see details of the symptoms in each system with their pathophysiology. But as an introduction, so during menopausal transition, a woman will have menstrual irregularity, which is typically they will have short cycle, and also she may have vasomotor symptoms like hot flash, night sweat, as well as sleep disturbance. And she may also have some psychological as well as cognitive impairment like depression, irritability, mood swings, as well as poor concentration and also poor memory. And the other also, she may have also some sort of sexual dysfunction like vaginal dryness, decreased libido, as well as dyspareunia. And she has also some urinary symptoms, so which we'll see in detail in the next slides. So as I said, normally during a workshop in 2001, there was reproductive age staging, which was called Strout-Plastin, which has 10 stages. So this staging of reproductive aging is used primarily to guide the female or the woman reproductive age. It has 2 stages after menopause, and it has 5 stages before menopause. And as you can see here, so there are different criteria to stage the reproductive aging. We use the menstrual cycle as well as some endocrine laboratory results like FSH, AMH, as well as on ultrasound antral follicle count. So based on these results, based on the 4 results, so there is a straw staging, so which is very important for guiding of the women reproductive aging. So as you can see here, so today we are concerned on menopausal transition and menopause. So during menopause, so mostly the menstrual cycle is somewhat irregular, and they will should have like short cycle, as well as some endocrinologically FSH level will be either decreased or sometimes maybe normal, and antral AMH level will be decreased because of decreased ovarian reserve, whereas antral follicle count will be decreased. So we'll see later ovary will be very small, and on ultrasound you may not see follicles during menopausal transition as well as postmenopause. So but during postmenopause, FSH level will be increased and AMH level will decrease, and antral follicle count it will be decreased significantly. Even you may not see the antral follicle count. So this straw staging is primarily used not for a diagnosis, but it guides to guide the reproductive age of a woman. Okay. And the next important area on menopausal transition is during menopause transition. So what will happen to each systems? Like what will happen to the endometrium, to ovary, menstrual cycle, and HPO axis? So during menopausal transition, as I said, it's a wide range of age before the menopause. So due to erratic hormonal fluctuations, so she will have symptoms. And on endometrium, what will happen is uh, so during menopausal transition, there will be decreasing of estrogen production as well as progesterone production. So her menses primarily, it's sometimes almost is an ovulatory. So due to that, if there is no ovulation, as you know, there will not be progesterone. Due to that, there will be endometrium will be exposed to persistent estrogen exposure. So in that case, so the risk of endometrial hyperplasia will be there. So during that time, the risk of endometrial hyperplasia as well as endometrial CA will be higher because of unopposed estrogen exposure of endometrium. So in that case, so you should be careful while you are assessing women during menopausal transition because of there is a risk of endometrial hyperplasia as well as endometrial CA. Because during that time, despite if they are asymptomatic, there is risk of around 0.1% risk of endometrial CA, and if she has AUB, the risk of endometrial CA is around 10%. So you should know that there is a risk of endometrial will be there during menopausal transition. And on ovary, in general, during pre-menopause, ovary have, as you know, greater volume and it contains follicles, as you see on the straw or in the reproductive aging staging. So ovary will be more larger, and you may see some multiple small unequivocal small words that means follicles. But during postmenopause, the ovary will be smaller volume and characteristically also you may not see you may you may not or you may not see follicles at all. So that is a typical change during menopausal transition and postmenopause. The other one is menstrual on regarding on the menstruation. So as I said, the interval between cycle may be altered by more than 7 days as well, and also women may not uh, uh, the expected menses may be skipped, and typically the cycle lengths become shorter. And sometimes during menopausal transition, so the menstrual cycle is somewhat irregular, and if it comes, it will be short cycle, and majority is anovulatory. And you should know that also during this time, so still she may have ovulation. Due to that, many women with menopausal during menopausal transition, so since they do have menopausal symptoms and they have irregular menses, they think that they don't have a chance for pregnancy. But you should know that there is still a risk of pregnancy, and you should counsel her not to discontinue contraception up to the age of 55 years. So this is what will happen during menopausal transition. The other one is HPO axis. So during menopausal transition, as estrogen and progesterone production will be decreased during that time. So due to negative feedback, there will be increment of FSH level as well as LH level. So as I said, there are different factors which influence, which affect the age of menopause. So menopause is average age is around 51 years, but it could be affected by many factors. But you should know that age of menopause is almost genetically determined, uh, but it can be affected by like smoking, chemotherapy, pelvic radiation, hysterectomy, and ovarian surgery. For example, in women with hysterectomy, so the risk of having premature menopause will be, risk of premature ovarian failure as well as premature or menopause will be, the risk is there. So those are the risk factors which affects age of menopause. So if you have a patient with a woman during menopause transition, so how you should evaluate, like you should have history, detailed history as well as detailed physical examination. Obviously, she will have menopausal symptoms like hot flash and other symptoms. So in that case, you should assess the symptoms as well as on physical examination. You should measure height, the weight, waist circumference, and BMI should be recorded, especially height, because of as age increase due to skeletal changes, especially on the vertebral, on the disc, their height will be decreased. So for follow-up, you should record the height. Regarding the weight during menopausal transition and post-menopause, so their weight will be increased due to different factors we see later, and others you should record for follow-up purpose. And the other one is you should also measure serum FSH level to reserve ovarian failure, because the menopausal symptoms to consider menopausal symptoms with ovarian failure. So if with good ovarian reserve, with good ovarian function, if you have menopausal symptoms, because there are other differential diagnoses. So you should know that there is loss of ovarian activity should be there, and pregnancy should be also excluded if applicable. And if women has came with some premature ovarian insufficiency, should also search for causes like chromosomal abnormality, infection, autoimmune disorder, smoking, and other causes. Okay? And the next one is hormonal replacement therapy, and about some history and controversies. So this is the most important discussion area. So this hormonal replacement therapy is extensively studied and it's evidence-based recommendation. And still, the recommendation is continuing to evolve because of different issues. As a history, normal estrogen therapy for menopausal symptom during 1960 and 1970, it gives really for almost for all menopausal symptoms. So by that time, the hormonal therapy was considered as it was effective drug to preserve the youth as well as to prevent chronic disease. So by 1960 and by 97, it was one of the most important drug to preserve the menopausal, to treat the menopausal symptoms as well as to prevent chronic disease. And but during 1970, epidemiologic studies revealed that women with especially intact uterus was associated with substantially elevated risk of endometrial cancer. So due to that, in 1980, so by FDA, they start to add progesterone they start to prescribe progesterone concurrently with estrogen in a woman with intact uterus. So due to the epidemiologic rise of endometrial, there was many observational study was conducted by like NHS, Women Health Initiative, and Elite Trials. So thus studies normally suggests hormonal therapy prevent osteoporosis, coronary heart disease, and also dementia in menopausal women. But there was some result fallacy, and they try to analyze all trial together and they bring a timing hypothesis. So this timing hypothesis is which it postulates that estrogen has differential effect on vascular tissue based on the timing as well as the stage of menopause. So, for example, you can see here the graph, the bar graph on the health outcomes in the Women Health Initiative. So, as you see here, based on Women Health Initiatives, so they give estrogen. You can see the estrogen hormonal therapy. As you see here, the risk of coronary heart disease, the risk of breast stroke, as well as all-cause mortality significantly decreased while they give in the early age, especially before 16 years. As you see, in between 50 to 60, 59 years old. So all coronary disease, breast as well as stroke, and all-cause mortality rate is significantly decreased. But as age of the women increase, so estrogen therapy increase, the risk of treatment is increased, like risk of coronary disease, risk of stroke, risk of all-cause mortality increase as age of the women increase. So by this trial, it's recommended to give hormonal therapy in the early menopause or up to 10 years of menopause, or in women age less than 16 years old. Okay, so this is the result of this trial. So due to this, how do you make decision if you have a woman and if you want to treat the menopausal symptoms? So how do you make decision? So during we should really discuss the treatment, the goal of the treatment, as well as the hormonal therapy risks and the benefits should be clearly discussed by the provider as well as and the patient. Okay, and it's also very important to know the clear indication as well as the risk benefit and the proper patient selection before initiation of hormonal therapy. And on the benefit, so you should counsel based on regarding the benefits. So hormonal therapy is most effective therapy for treatment of vasomotor symptoms, as well as it's also very effective in prevention of osteoporosis and osteoporosis related complications like fracture. And you should also tell the women that hormonal therapy it treats genitourinary symptoms. Okay, and also you should also tell the women that when it is initiated soon after the onset of menopause, hormonal therapy decrease the risk of coronary heart disease rate, as well as it enhance insulin action and it prevent Alzheimer's disease. Okay, so these are the benefits you should inform to your patient. The other one is the risk is, as I said, the risk of hormonal therapies. It may increase the coronary heart disease risk if initiated, especially if it is initiated in a woman aged more than 16 years or in those who are 10 years of postmenopause. So in this case, so the risk of hormonal therapy is higher because it may increase the risk of like stroke, venous thromboembolism, and cholecystitis, as well as other age-related mortality will be increased. The other one is breast cancer risk is also modestly increased if you give estrogen progesterone therapy more than 4 to 5 years. And for women with uterus, estrogen therapy increases the risk of endometrial uh, um, hyperplasia and endometrial. So after you consider the benefit and the risks, so next you should know the clear indications. There are three important indications for hormonal therapy, especially the first one is the most important indication, that means for treatment of bothersome vasomotor symptoms as well as genitourinary symptoms, because if the symptoms are not that much, you have other non-hormonal option we'll see later. The other one is also in prevention of osteoporosis in high risk menopausal women, menopausal women. So in prevention of osteoporosis, you may use hormonal therapy. The other is also in treatment of hypoestrogenism due to hypogonadism or surgical menopause or premature ovarian insufficiency. Here, so the next important thing is there are different class of hormonal drug classes. Okay, I think it's not visible. So there are different hormonal classes which used as a short term for 5 years for menopausal symptoms. So you may give estrogen alone, or you may give estrogen with progesterone and other hormonal therapy, which have different effects on different organs like breast, uterus, and on bone and other areas. So the other one is you should know the contraindications for hormonal therapy. Regarding the contraindication, uh, especially estrogen shouldn't be used in a woman with any of the following conditions, like if you have undergone undiagnosed abnormal genital bleeding, if you have known, suspected, or history of breast cell, known or suspected estrogen-dependent malignancy, and if she has active or prior venous thromboembolism, and liver dysfunction, untreated hypertension, known or suspected pregnancy, estrogen is totally contraindicated. And the other also on the other table you can see also um, there are many contraindications you should see or you should assess your patient before providing hormonal therapy. Those are the contraindications for hormonal therapy. So the next topic will be vasomotor symptoms, VMS. So the next will be on vasomotor symptoms. So vasomotor symptoms mean, as you know, the exact pathophysiology is not known, but women will have a sudden wave of heat, which spreads from the upper body and face lasting 1 to 5 minutes, and ideally it begins an average of 2 years before menopause, and most experience them for more than 1 year. Up to 85% will experience the symptoms for 1 year, but up to 25 to 50% it may extend to up to 5 years, and 50% will have experiences for around 15 years. During the symptoms, normally the skin temperature rise by 10 to 50 degrees centigrade. So due to peripheral vasodilation, and 90% of hot flash will have also sweating. And during the symptom, so systolic blood pressure will be raised, heart rate will be increased, and metabolic rate also increase. And due to that, she may have also chills. And also she may have also like palpitation, anxiety, irritability, and panic attack during the symptoms, onset of symptoms. So as I said, the pathophysiology of vasomotor symptom is not clearly known, but it's due to dysfunctions of thermoregulations, which is uh, sorry, thermoregulations in the hypothalamus, so which could be affected by different factors. So there are three important hypotheses for the cause of vasomotor symptoms. One is due to estrogen withdrawal. The other one is due to norepinephrine and serotonin. The other one is KNDY, a neuron class in the hypothalamus. So on estrogen it play a vital role because due to estrogen withdrawal, so there will be rapid uh, due to estrogen withdrawal. So she may have like symptoms of VMS, but this VMS is not common or even not happen in women with gonadal dysgenesis who don't have like normal estrogen levels. So it's this VMS is commonly happen in a woman with chronically low estrogen concentrations. Sorry, in a rapid estrogen withdrawal. So it doesn't occur in a woman with chronically low estrogen concentration, like in those with gonadal dysgenesis. The other one is norepinephrine and serotonin. It plays a vital role in onset of VMS. So because as you know, it's a neurotransmitter which is responsible to lower the set point of temperatures. So due to that, if you give norepinephrine receptor blocker, so the symptom will be the symptom is resolved. Due to that, it's believed that norepinephrine also play a role in PMS symptoms. So the other one is risk factors for vasomotor symptoms. So normally the risk factor is almost similar with menopause. So women with those early as well as surgical menopause race is common in black. BMI, both extreme, sedentary lifestyle, smoking, and also use of selective estrogen receptor modulators for other problems. It will increase the risk of worsening of vasomotor symptoms. So the next one is how to treat women with vasomotor symptoms. There are different options of treatment. One is hormonal replacement therapy. You can see classify as hormonal, pharmacologic, and non-pharmacologic. The pharmacologic one is hormonal therapy and non-hormonal therapy. On hormonal therapy, so you can use either estrogen or estrogen with progesterone or progesterone alone, and you can use also selective estrogen receptor modulators. So especially for estrogen, so the best candidate for hormonal therapy is women with younger than age of 60 and those within 10 years of menopause onset. So hormonal therapy is preferable after you rule out the contraindications, after you assess the contraindications. So hormonal therapy is preferable for those women. And the other one is non-hormonal agents we will see later. So on estrogen, there are uh, different preparations for estrogen. So you can see here the table. There are different preparations for estrogen. So estrogen has some oral form, transdermal form, and vaginally. So after assessing the woman, so you can give estrogen because for example, commonly we use like primary, uh, which is oral form, and also there are different preparations. So but the principle here is you should use the lowest effective doses. And the other one is progesterone. So in case of progesterone, so still there are different progesterone forms like especially in women with uterus. So it's recommended to add progesterone to decrease the risk of endometrial hyperplasia and endometrial CA. The other one is selective estrogen modulators like benzodoxifene. So it's also used for the treatment of vasomotor symptoms, especially primarily we use this one for osteoporosis, prevention of osteoporosis, and it's recommended to combine with estrogen to treat for to treat the vasomotor symptoms. The other one is a non-hormonal agents, as I said before, serotonin as well as norepinephrine play a vital role in pathophysiology of the vasomotor symptoms. So if a woman is not a candidate or if she has a contraindication for hormonal therapy, so those agents are ideal for them. So you can use selective serotonin reuptake inhibitor, you can use the norepinephrine receptor inhibitors, and you can use also gabapentin, pregabalin. So almost they are effective, especially in women with who have contraindication for uh, hormonal therapy. So the other one is supplement as well as lifestyle changes for vasomotor symptoms. So normally in a woman with vasomotor symptoms, sometimes she may have contraindication for hormonal therapy and also the symptoms may not worrisome her. So in that case, you may counsel to have some changes in her life, like she can use fans, she may lower the room temperature as well as consuming cool beverages, and she should also avoid triggers like alcohol, caffeine, and spicy foods. The other one is also weight loss and non-sweat inducing exercise and mindfulness stress reducing therapy may provide quality of life uh, and it significantly improves the vasomotor symptoms, especially the mindfulness stress inducing therapy is very important. So we use this therapy for other purpose, like even for chronic pelvic pain. So in this case, you should uh, focus on like breathing exercise and other gentle exercise like yoga, which incorporates mindful movement and stretching to enhance the body awareness as well as relaxation. The other one is the next one is bone health. So as you know, one of the most important change, physiologic change, or one of the most important thing during menopause is bone. So almost all bone mass in the axial skeleton will be accumulated in young women by late adolescence. As you know, also there are two types of bone. So like the cortical bone and trabecular bone. So cortical bone is a peripheral skeletal bones like the arm and legs, whereas the trabecular bone is they are a part of like axial skeleton like spine, the pelvic bone, and the proximal femurs, which are highly affected during menopause. So during menopause, the axial bone is significantly affected. So the maximum skeletal maturity is attained, as you know, in between 25 to 35 years. So after the age of 35 years, after you have maximum bone mineral density, at this age, you will have the bone mass will decrease at approximately 0.4% each year. And in the absence of therapy, hormonal therapy, the rate will be increased to 2.5% per year for the first 5 to 10 years, and then it will slow to 1% per year after 10 years. So, and also as you know, normally this bone is just like it's a dynamic living tissue, or which is on a continuous process of destruction and rebuilding, which is carried out by osteoclasts and osteoblasts. So our concern during menopause is osteoporosis because during hormonal changes, okay, the risk of osteoporosis will be increased. So and osteoporosis associated complications will be there. That's fracture. So because fracture is significantly affects the morbidity as well as the mortality of women. So women during menopause are highly affected by osteoporosis. So it's one of the big issue during post-menopause. So we can screen women at high risk for osteoporosis. We can prevent women to prevent. We can prevent osteoporosis as much as possible, and also if there is osteoporosis, we can also treat, because the point here is if there is osteoporosis, there is risk of fracture, and fracture also, if there is fracture, it will increase the risk of like morbidity as well as mortality. So in that case, uh, it's a big woman health issue during menopause. So based on American National Osteoporosis Foundation, so around in US, for example, around there are 10 million have osteoporosis and around 3 million have osteopenia, and of this 40 to 50% experience osteoporosis related fracture during their lifetime. So the common area for osteoporosis and fracture is the vertebra, especially the lumbar one is highly affected, and the femoral neck and also wrist is the most commonly affected. And when you see the risk factor for osteoporosis, age is the most major risk factor, and there are other non-modifiable as well as modifiable risk factors. The non-modifiables are age, race, early menopause, prior adult fracture, family history of osteoporosis as non-modifiable, but the modifiable one is inadequate intake of calcium and vitamin D, smoking, low body weight, excessive alcohol intake, and sedentary lifestyle are the modifiable one. So you can see also here the major and the minor risk factors. So these are very important to select for to select candidates for treatments of osteoporosis. So how do you diagnose osteoporosis? Osteoporosis can be diagnosed by DEXA. It is a gold standard for the diagnosis of osteoporosis. So you can, it is dual energy X-ray. So you can see the lumbar vertebra and from femoral neck. So it will report as report as a T-score. So WHO has its own criteria for bone mineral density based on DEXA scan. So you can the normal bone mineral density is in between plus 2.5 and minus 1, and osteopenia is if T-score is between minus 1 and minus 2.5, and if osteoporosis is if T-score is at or below minus 2.5, and if it is with T-score less than minus 2.5 with one or more fracture, it is severe osteoporosis. Is very important for treatment as well as so the gold standard for diagnosis of bone mineral density is osteoporosis is assessing the bone mineral density by DEXA scan. There is also Frax. There is also Frax. This is it's an online. It's online calculation. So you can use 11 parameters in between the age of 40 to 19 years. So you will give those factors, and it will calculate by itself. It's an online application. So this Frax is important to identify patients who might benefit from pharmacotherapy, or so in this case, it's important to assess osteopenia. So so it's very important also to screen women at high risk for osteoporosis. So based on this algorithm, you can screen based on you can use this algorithm to screen a woman for osteoporosis. Like if her age is greater than 65, you can do bone mineral density using DEXA scan, and if she has osteoporosis, you can start treatment directly. And if the bone mineral density is almost if she has osteopenia, you can use drugs, and if she's a high risk, and you can treat. And I think it's clear, and you can see you can use this algorithm to screen osteoporosis. So the next one is the most important thing here is how to prevent osteoporosis. So we see how to diagnose osteoporosis and how to screen osteoporosis, and next how to prevent osteoporosis. So you can uh, 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 prevent osteoporosis in postmenopausal. Just counsel on risks of osteoporosis. One, the other one is assessing the secondary causes. And for women above the age of 51 years and older, above the age of 51, you should encourage the daily dietary intakes of calcium up to 1,200 milligram and vitamin D up to 1,000 international units daily, and regular weight bearing and muscle strengthening exercise. Advice against smoking. Also, you should also assess for fall risk, because 90% menopausal associated fracture is due to fall, due to falling down accident. And you should also measure the height annually. And in women above the age of 65, bone mineral density testing DEXA scan is recommended, as you see on the algorithm. And in a postmenopausal woman between the age of 50 and 65 years, bone mineral density may be tests may be recommended based on risk factor profiles. And for patients on pharmacotherapy, perform bone mineral density testing every 2 years after you initiate therapy, and every 2 years thereafter. Okay. So the next one is osteoporosis treatment. So there are 4 indications to initiate osteoporosis treatment. We'll see options of treatment, but as an indication for osteoporosis treatment, a woman, post-menopause woman with uh, osteoporosis, postmenopausal women with osteoporosis, or uh, those women with osteoporosis plus vertebral or hip fractures, whether she's postmenopause or not. And the third indication is those with prior fragility fractures. And the fourth one is those with high fracture probability. So those are the indication for treatment of osteoporosis. So the goal of treatment here is either stabilizing or increasing bone mineral density by decreasing bone destruction, and also by increasing building of the bone. So just like other symptoms, so on the pharmacologic, the therapy has pharmacologic as well as non-pharmacologic. So on pharmacologic, you can use agents which reduce bone destruction, like estrogen, selective estrogen receptor modulators, and bisphosphonates, and other drug options like so the goal of this one is just to increase bone mineral density by decreasing the bone destructions. And the other agent one is stimulate bone formations. So in a woman with in women with osteoporosis, so you should also involve some endocrinologists as well as rheumatologists and other, if it's available, osteoporosis specialists to have a good outcome. The other one is hormonal therapy. It is slow bone destruction rate, and which results in bone mineral density increment, and it reduces osteoporotic fracture rate by 50%, where if it started soon after menopause. Okay. The other one is the selective estrogen receptor modulator, like benzodiazepine. It's indicated for VMS and postmenopausal bone loss prevention. If you give the selective estrogen modulator alone, so it increases the risk of VMS. So you should add estrogen with selective estrogen modulator. So there are also other options like bisphosphonates for osteoporosis, parathyroid hormone agonists for osteoporosis treatment. You can use also this. And the other one is the non-pharmacologic therapy for osteoporosis. So the non-pharmacologic interventions are is a cornerstone of osteoporosis prevention, actually. And as you see on the table before. So dietary modification, exercise program, as well as fall prevention strategy and education is the most important. So daily calcium intake is essential for bone maintenance. As you see here, so the daily intake of calcium should of for women aged in between 31 to 50 years should be 1000 milligram daily, and if it is above the age of 51 it should be up to 1200 milligram is recommended. So, and calcium supplementation should be also combined with vitamin administration, and it will reduce significantly the bone loss as well as fractures. So for women at high risk of osteoporosis who are older than 70 years, so daily vitamin D should be increased. The other one is just like other menopausal symptoms, caffeine consumption uh, uh, should be decreased, as well as sorry. So the other one is here is, as you know, for 90% of hip fracture is associated with falling down accident. So in women with for postmenopausal women, so prevention of falling down accident is very important. So you should uh, counsel her to avoid falling. So the other one is the other menopausal issue is genitourinary syndrome. So previously it was the term was like vulvovaginal atrophy, but it's currently we use genitourinary syndrome of menopause because vulvovaginal is not inclusive. So because during menopause, not only the vagina, the vulva, but also bladder, the urethra, and other urinary tract also will be involved. So due to that, it's better to use genitourinary syndromes of menopause. So since there are high concentrations of estrogen receptors, so whenever there is estrogen withdrawal, so the vaginal mucosa, the vulva, bladder, urethra, as well as the pelvic floors is significantly affected. So during menopause, as well as during menopausal transition due to low estrogen, so vagina will be shorter and narrow, as well as it lose flexibility. Vaginal mucosa become also thin and shiny, and the rig also flattened. And in that case, also even the urethra also affected. So women during that time, which is a clinical feature actually later. So women with during menopause, she will have some sort of vaginal dryness, and this dryness is the most prevalent symptoms. This is due to the physiologic change due to hypoestrogenism. So due to this, the negative effect of sexual function, the partner relationship, and quality of life, it affects, so vaginal dryness and dyspareunia significantly affects sexual function, the partner relationship, and the quality of life. So regarding the treatment of the genital symptoms, so you have a non-hormonal as well as hormonal therapy, especially the non-hormonal one. You can use water or silicone-based vaginal lubricants as well as vaginal moisturizers for vaginal dryness. And you can use also regular sexual activity, help to address symptoms and prevent progressions of vaginal narrowing. And you can use also some graduate vaginal dilators just to prevent the progressions. The other one is hormonal therapy, estrogen, you can use vaginal DHA, and others for genital genital symptoms of menopause. So there are different preparations for hormonal preparations for these symptoms. So these are the most common used, especially vaginal cream like Primarine. And so you can start from the lowest dose, and you can uh, access every 2 to 3 months. It's effective. It is effect, and you can also in tablet. There are different preparation forms you can use this. And the other one is the other important topic here is also sexual dysfunction and urogynecologic changes. So okay, so as I said, the prevalence of vulvovaginal atrophy as well as female sexual dysfunction is approximately about 55% of sexually active postmenopause women, and women with sexual dysfunction were nearly 4 times more likely to have vulvovaginal atrophy. So as you know, sexual dysfunction is common during postmenopause, which is due to primarily the vulvovaginal atrophy. So due to physiologic changes, that means due to hypoestrogenism, there are changes on the genital systems. Due to that, sexual dysfunction is common. There are different types of sexual dysfunctions, as you know, and also pelvic organ prolapse and incontinence also there. So because especially stress incontinence because of shortening of the urethra, there is associated stress urinary incontinence. And also women due to hypoestrogenism, as I said, so the urethra, bladder there are a lot of estrogen receptors. So due to that withdrawal, so women also have some urinary symptoms like dysuria, urinary urgency, urethral eversion, as well as prolapse. Also risk there recurrent UTI also there. Urethral shortening also there due to menopausal atrophic changes, so which results in stress urinary incontinence. This has a sexual dysfunction, as I said, it's already discussed. The other one is risk of depression. So during menopause, the risk of depression is common, especially it's more common during menopausal transition. And as due to significant and erratic hormonal fluctuation during menopausal transition, is risk women who have repeated episode of depressions. So it's also uh, so it also significantly affected by like other. It can be affected by emotional stresses like from major illness, caring for an adolescent or aging parent. Due to there will be risk of divorce or career change or retirement due to this issue when it always hormonal changes, so risk of depression is there. So women during menopause, if she has depression, and you can use antidepressant medication concomitantly for treatments. And you should know that also hormone therapy is not considered treatment for depression. And also sleep quality also decline with age, but menopausal transition appear to contribute. But and also the severity as well as the prevalence of both seem to peak during in the late menopausal transition. Uh, Almost the pathophysiology is not clearly known, and you should know that hormonal therapy can improve some sleep disturbance as well as sleep quality. And you should rule out other manageable causes like anemia, thyroid disease, and others before you start hormonal therapy if sleep dysfunction is the only complaint during menopause. The other one is cognitive dysfunction. So during menopause transition as well as post-menopause, the cognitive performance of women significantly decrease. It could be due to aging, but even in the early menopausal transition, so their intellectual as well as cognitive function significantly decrease. The exact cause is not that much known, but hormone therapy is not that much recommended for this indication. The other one is cardiovascular changes. This is one of the field complication or risk during menopause. As I said before, on the hypothesis theory, so women, as you know, also women during women have much low risk for cardiovascular event in before menopause than men, but after menopause, due to hypoestrogenism, so the atherosclerosis as well as cardiovascular accident is much higher in women than men. due to loss of estrogen protective effect. So that's why we should really be careful while we treat a woman during post-menopause. So when you have start hormonal therapy, the risk of cardiovascular accident is increased. So you should really assess the cardiovascular risks before you start hormonal therapy, because estrogen is almost cardioprotective during reproductive age due to that. So women is less risky for cardiovascular events than men during the reproductive age of the same age, unlike menopause. The other one is weight gain and fat distribution. So weight gain is one of the most complaints during menopausal transition. This is due to primarily slow metabolism, so which leads to low calorie requirement. So in that case, women will complain some central obesity, so which is associated with other age related like TM, risk of hyperlipidemia, hypertension, cardiovascular disease, as well as mortality will be increased due to this metabolism change. So for this, lifestyle intervention, like including exercise and healthy nutrition, is recommended. And hormonal therapy also improves some body fat distribution, but it's not recommended as a treatment for central obesity. But if you start for other indications, she may be benefited for it will improve the fat distributions, but you don't start hormonal therapy for that. So the other one is breast change. So it's obvious during perimenopause due to estrogen and progesterone has a proliferative effect on rectal and glandular structures. But at menopause, due to withdrawal, so there will be reductions due to withdrawal of hormones. There will be reduction of in breast proliferation. The other one is dermatologic changes. Around 30% of collagen may be lost within the first 5 years after menopause, and so skin aging. Sorry. So during menopause, so hormonal dermal changes like includes like reducing thickness of the skin with lower collagen content, decreased sebaceous gland secretion, loss of elasticity, and decreased blood supply will be there. So due to that, there will be dramatic dermatologic change during post-menopause, which is primarily due to one is intrinsic aging as well as due to photo aging from sun exposure or other environmental. So this is my reference. Thank you for your time. Thank you.
Okay, thank you very much, Dr. Abebe. It was an amazing presentation. So we can move on to the question and answer section. So participants, if you have any questions related to today's topic, yeah, you can write down your questions in the chat box. So, Doctor, can you access the chat box?
Yeah.
Yeah, so far there's no questions, so we will be waiting for a few minutes if there are any.
Yeah. A reasonable duration of treatment with hormonal therapy. There is actually there is no specific duration of treatment for hormonal therapy, but the most important point here is if you see the indication is, so majority of symptoms is more worrisome in the last 2 years before menopause as well as for the first 5 years. So as much as the women symptoms improved, you can continue. There is no upper limit for hormonal therapy, but you can discontinue at some point, and if the symptom not worsen and if the symptoms improved, so you can discontinue as well. So you don't need to. There is no specific time to discontinue hormonal therapy. The point is you should follow for the the response of the treatment. So if 65 years old postmenopausal women for the past 10 years, with new onset of dementia cannot take hormone. Hormonal therapy is not recommended. Is not recommended for treatment of dementia. Okay, so it's not an indication for hormonal therapy. Rather, you use other therapy. Even if the age is less than 65, so we don't use hormonal therapy for dementia. So the other question is, any difference in management between age-induced menopause and medically induced ones, like caused by chemotherapy? So in this case, especially if obviously if it is medically induced menopause, just due to like surgery or due to chemotherapy or due to ovarian surgery. So commonly the age is almost younger, so hormonal therapy is more they are candidate for hormonal therapy. But for age-induced menopause, so the risk of hormonal therapy associated risk is more increased, especially like for example, if her age is more than 60, as well as if is the duration of menopause is more than 10 years. So the risk of hormonal therapy is more risky. So due to that, medical induced menopause is better candidate for hormonal therapy. So the other question. So age limit for hormonal therapy is just by comparing the risk and benefits. So based on the trials, as I said, the Women Health Initiative trials, so as the age of the women increase, the risk of hormonal therapy increase. So it's based on the risk and benefits. So women below the age of 60 and or women within 10 years of menopause, they are more benefited from hormonal therapy. But if you give hormonal therapy after the age of 60, the risk of like venous thromboembolism, stroke, or mortality rates by any other problems is significantly increased. So they will not be benefited from that. So after the age of 60 or after 10 years of menopause, so you better use other option or especially non-hormonal therapies recommended. So that is my suggestion. So the duration of treatment for hormonal therapy already I explained. There is no specific time you give, and if the symptoms improved, then you'll see for a time, and if she's fine with the discontinuation, so you can discontinue. Otherwise, there is no upper limit for for discontinuation. Average Ethiopian women menopause age. I try to search, but still I didn't get. So let's see. Best sleep for regarding sleep disturbance. You should know that it may not be only associated with menopause. You should really rule out other causes like anemia, thyroid disease, and for short term, if you can use sleep inducing drugs, but you should controlling with like sleep timing and duration, improve the bedroom environment as well as relaxation and biofeedback techniques. You may use some improve counseling on that issue, but or regarding severe sleep disturbance during menopause, it may not be only related due to not it may not be related due to menopause. So you should search for other causes if it is severe sleep disturbance. and you can improve the sleep quality by assessing many things. Thank you.
Okay. Thank you very much, Dr. Abebe, for the amazing presentation and also addressing all the questions in the chat box. So, on behalf of Players Ethiopia, all our participants, and the International Society of Sexual Medicine, I would love to thank you for taking the time to present on our seminar, and I hope we will be seeing more of you on future seminars as well with other and related topics. So if you have any last remarks you want to add, let me give you the stage one more time and we can end the session.
Thank you. I don't know. Have a
Okay.
nice night. All right.
Thank you, and good night, Doc.